proceed with the start. Good afternoon, everyone who's joined us today for the Next Step Education Series. Thanks very much again for your interest. I appreciate you joining us. Just before we start, just to explain what we're doing today is a little bit different. We're going to have three different presenters doing some short presentations on just some topical issues in addiction medicine. So I'd just like to show my respect and acknowledge the traditional custodians of the land on which we meet today, and pay my respect to elders past and present, and introduce now Thomas Dorm, who's the Next Step Senior Pharmacist, and for his presentation. Thanks, Thomas.
Hi everyone. So my topic is on the new and amended PBS listings for opioids. So to begin with, I'll briefly explain the difference between the TGA and the PBS for people who may not be familiar with it. I know that there could be some pharmacists listening, and you guys would already know this full bottle. But anyway, for the benefit of the other professions, the TGA regulates all therapeutic goods in Australia. So all medications in Australia are therapeutic goods and must be reviewed and registered with the TGA. Now, there are exceptions where medications are not registered on the TGA and can be used, but they require formal application and then get approved, to be approved as well. So for example, there's very few products that are cannabis-based that are registered with the TGA. So the majority of cannabis-based products in Australia must be approved by the TGA and then get imported. The PBS is a list of all medications available at a subsidised price. So if a medication is listed on the PBS, people with a Medicare card will usually pay around $41. People with a healthcare card will usually pay about $5.60 or $6.60 for their medication. The rest of the cost of that medication is subsidised by the government. So for example, hepatitis C medications, thousands and thousands of dollars, but most people with Medicare card will only pay $41. We're very lucky in Australia to have a system like this. If a medication is TGA registered but not PBS listed, then the patient will have to pay the private price or the full price. So for example, naltrexone is only listed on the PBS for treatment of alcohol dependence. So if a prescriber were to prescribe it for opioid abstinence, then the patient will have to pay the full price, which is around $120, $130 for a month's worth. Okay. So what changed with opioids on the 1st of June? And we do apologise for the delay in this presentation. It was scheduled for a little bit earlier, but things were scheduling, but better late than never. So in response to the concerns regarding the harms associated with prescription opioids, the opioids listed on the PBS were amended. So these included adding new listings for half-pack sizes, increased restrictions for full-pack sizes, and new and amended clinical criteria, prescribed instructions, and administrative advice. So we'll go through and clarify these points in the next few slides. This is only one strategy of many by the government to support appropriate use of opioids. So the other strategies included education and awareness campaigns, changes to clinical guidelines, and ongoing compliance monitoring by the respective Department of Health in each state. So firstly, there are now new listings for half-pack sizes for doctors to prescribe. So whilst the full-pack size, or the 20-tablet packs, are still available, the option of a half-pack size gives a simple way to prescribe smaller quantities of immediate release formulations for short-term treatment of acute severe pain. And this is a list of the opioids with a half-pack size on the PBS. And a good rule of thumb, I think, is if it's in an immediate release tablet, then it's generally for acute severe pain, and there will be a 10-pack half-pack size available. So secondly, there are increased restrictions on full pack sizes, and thirdly, the clinical criteria for prescribing opioids has been amended. So what does that mean? So previously, some opioids on the PBS were unrestricted, which meant if I was a prescriber, I could prescribe it for any condition. So if someone comes in with a headache, I could give Panadol for it. From the 1st of June, all opioids under PBS are listed as restricted benefit now. And they should only be prescribed for patients with severe pain and meet one of the following 3 criteria. So the patient must have experienced inadequate pain relief from the maximum dose of non-opioids or other opioids, or the condition must be such that the maximum dose of a non-opioid or other opioid is inadequate, or lastly, the patient can't use a non-opioid or other opioid because of allergies or contraindications. So the only exception to this rule is that codeine tablets can still be prescribed for cough depression under the PBS. Hopefully our patients don't know that. Opioids for chronic severe pain, they were previously restricted benefit. All of them have now moved to authority required. So this means that the prescriber must write it on a separate authority prescription with an authority code. So this added authority layer ensures opioids prescribed for chronic pain meet the clinical criteria. And the general rule of thumb is that if a medication is a modified or a sustained release, a tablet or a patch, it's reserved for chronic pain and it must be on an authority prescription. The criteria for prescribing opioids for chronic pain are the same as the criteria for severe acute pain, with an additional 2 criteria, which I've highlighted in orange. So firstly, the patient must have a condition that requires daily, continuous, long-term therapy. And secondly, the pain is directly attributable to cancer. So hydromorphone tablets, methadone tablets and injections, and fentanyl have an extra condition where the patient must not be opioid naive. So this narrower indication for these medications should hopefully reduce the number of new patients that are put straight onto hydromorphone, methadone, and importantly, fentanyl.
Yeah.
So what else should prescribers know? So firstly, these changes are only to do with the PBS. So if a prescriber was to prescribe something privately, patients can still pay the full price or the private price, and they don't need to meet any of these conditions. Secondly, GPs need to update their prescribing software to reflect these new changes on the PBS. I've got a lot of colleagues in the community pharmacy where after this change in July, had a lot of unhappy patients because they came in with their usual prescriptions and they were told that can't get this on the PBS anymore. And the prescribers who haven't changed their software are not aware of this. Thirdly, it is the prescriber's responsibility to ensure the patient meets the clinical criteria before prescribing these opioids. Once it gets to the pharmacy, the pharmacist will dispense it and presume that it is for who it is for. And fourthly, if the patient requires increased quantities for chronic pain, it is still available, but they would just need to request it directly via telephone or written application to Medicare. And lastly, I put this point in red because I think it is applicable to specialist prescribers who may be referred patients for pain and addiction assessment. If the patient requires opioids for more than 12 months, the patient must be referred to a pain specialist or an alternative prescriber. And the alternative prescriber is not specified. So it may be another GP, could be an addiction consultant for a review. And every time there is a authority application, the full name of this second prescriber will need to be on that authority application to Medicare. So it's just for us to be aware that our name, or well, your doctor's name, will be on the application.
When you say application, do you mean the authority's prescription?
When they apply for authority to Medicare, then they'll need to put the second prescriber's name on that application for authority. That's it.
Thomas, thanks very much, Thomas. That's really, really important information for us and really clearly explained. having said that, there's so much in that. Do we have time to go back just quickly to ask a couple of questions?
I would have thought so, yeah, absolutely.
So Thomas, can we go back to the slide, just a couple, next one, back. So, just excuse my slow brain today, but so does that mean that you can't prescribe chronic opioids unless it's attributable to cancer? So there's no more non-cancer opioid prescribing?
It's an or.
It's an or.
Yeah.
Okay.
That's what I
saw the and at the top, and
That's right. That's what I thought.
Right.
There's an or after.
Okay. All right. That was my main question. And yeah, so it's a really important point that you need to be opioid tolerant to some extent for hydromorphone, methadone, or fentanyl patches. Yeah.
And currently, if a patient goes to the pharmacist now with a regular script that says oxycodone sustained release, 20 tablets and 2 repeats, it won't be dispensed because it needs to be on an authority script, so the patient needs to go back?
Yeah, so that script is still valid if it's privately paid. So we can't dispense it under the PBS subsidised price.
Yep.
And if it's OxyContin, I presume that it can be quite expensive.
Right. Interesting. Okay.
When does the pharmacist's responsibility end? So they just dispense the medication if the script's there, assuming the authority criteria are fulfilled.
Yes. So once the prescription gets to the pharmacy, our responsibility is to make sure that it's the correct medication to the right patient and the patient knows how to take it properly. We don't know if it meets the clinical criteria on the PBS. If it's written in authority and there's a streamlined authority number, we presume that it meets the clinical criteria.
Okay.
I guess there's more ways of the Department of Health or whoever, the TGA, to follow up on prescribers that are prescribing lots of opioids and to check that patients are meeting criteria. Would that be these new guidelines or new restrictions?
That one I'm not sure of.
We're looking for, you need authorisation, so you've got to actually make a statement when you're getting authorisation, which is without it you don't have to.
Yeah, so there was a point there that if you need something for chronic pain that's more than 1 month or 3 months, you need to telephone and write to the Medicare. So that added extra layer ensures that the patient actually meets the criteria.
I'm just thinking of going back over some prescribers that might be identified or flagged as prescribing a lot of opioids, and then if there was an audit process, that would give
Sorry, Swan.
Are you happy for us to be involved?
We might have to be if we're doing assessments on people who've got prescription opioid. I don't think that'll be optional.
Yeah, like the way you can see the pain, it can be a long time for it to be pain. They need an online prescription. Okay. And question number 2, is there any recommendation, because of the changes happening, de-prescribing is going to be the next reality. Is there any guideline from the as to how to de-prescribe?
There's lots. Yeah. Too big a topic for now, but there's a lot of material going into that, heaps on the internet. We could go over that at some stage. Doctors' meeting, talk about this. Great.
All right, thanks very much, Thomas. We appreciate it. Might need some help here, Tom. Very good. All right. Okay, so introducing myself, Mike here. I've got a few slides relating to alcohol, and this is basically how we advise patients on safe alcohol use. So it's the guidelines that we've used for quite some time and how they've changed. So just very quickly, a little bit of epidemiology of alcohol use in Australia. So lots of Australians drink alcohol. Fully more than 1 in 20 Australians drink alcohol every day. And drinking alcohol every day is more common amongst older Australians, and arguments with increases with age. It's just the demographic shifts, obviously with time, rather than alcohol increases. It's the same people drinking daily and becoming older. About 17% consume, so almost 1 in 5 consume in excess of lifetime risk guidelines, and 1 in 3 in the last 12 months have consumed in excess of single occasion guidelines. So we don't really need to compare, I don't think, with other countries here. We just have to accept that in Australia, at least, we drink quite a lot of alcohol, and alcohol is a significant problem in our society. With regard to the last 2 points, consumed in excess of lifetime risk guidelines and consumed in excess of single occasion risk guidelines, what is that? So the NHMRC publish guidelines on lifetime risk, and those currently say that we should stay at less than or equal to 2 standard drinks on any particular day in terms of regular drinking. And what that means is it reduces your risk of chronic disease or injury related to long-term alcohol use. So things like liver cirrhosis, cardiomyopathy, atrial fibrillation, those sorts of things, and cancer particularly, reduces your risk to about 1 in 100 if you drink at that level. Single occasion risk, if you're drinking 4 or less standard drinks on any particular occasion, then your risk of accident or injury is at about 2-fold someone who hasn't consumed any alcohol at all. So the government has NHMRC in particular, has accepted that as a reasonable risk for the Australian population, and that's where those guidelines come from, and that's what we're advised to talk to people about now. So if I speak to someone who wants to control their drinking, and they would say to me, I accept that I drink 6 beers a night, and on Saturday I drink 10. What I would work with that person towards is, if that's their aim, then we work getting down to these particular guidelines, to staying within NHMRC guidelines and explaining why. Okay, so that's why the guidelines are important. So what's happened to the guidelines? Well, what about these guidelines? Sorry, just a step backwards. So those guidelines we just spoke about were published in 2009. And the evidence base that was reviewed for that publication was from between 2000 and 2007. So given that the average estimated time to publish in a scientific journal is about 4 to 5 years from concept to publication, most of the data that was used in those guidelines comes from as far back as 1995, and we're using those guidelines now. So the information in those guidelines can be as old as 25 years. Which brings us now to the new draft guidelines that were released for public comment between the 20th of February 16th of December and 20th of February this year. So public comment's now closed. The final draft of these guidelines is expected in late 2020. What are the main changes due to? So certainly the relationship between cancers and low-level alcohol use, so less than a unit a day, has much stronger than previously thought. So that's the first point. Second point is that we know that drinking alcohol increases your cancer risk, and that your cancer risk increases with the amount that you use. So cancer is an important factor here. And then the other thing is there's much more uncertainty now about the proposed protective effect of alcohol. So where we had the J curve, so-called famous J curve, and that still fits with quite a few publications, but there's more evidence now and more uncertainty about the previous evidence that drinking 1 to 2 glasses of, for example, red wine a day reduces your cardiovascular risk and reduces your risk of diabetes. So because of that uncertainty and because of more evidence related to cancer risk from lower levels of alcohol, the guidelines have been revised. They're the major points. I mean, these guidelines are 200 pages long, which pick the major points. So the key change is that the lifetime risk guideline now has been reduced from 2 standard drinks a day to something less, so 10 standard drinks per week. Okay, so that's basically the major change. As I said again before, these guidelines are based on mathematical modelling that show and systematic reviews of evidence that show that your risk of death is less than 1 in, or around about 1 in 100 if you drink at that level. As we probably know, but complex mathematical modelling shows that your risk of death from drinking alcohol increases with the volume that you use, and it also increases with consumption over shorter periods, so higher volume used over shorter periods. I think when you're advising patients, it's really important to recognise now that there is there's uncertainty about assigning any level of alcohol to no risk. So any level of alcohol use saying that there's no risk. I think we need to be very cautious with that. Alcohol is classified as a group 1 carcinogen, which means, for those who are not aware, it is known to cause cancer. It is established that it causes cancer in humans. In terms of medical exams and nursing exams, it's pretty easy with alcohol. What cancers do alcohol cause? Well, if you look at where you pour the stuff in to the end, and then when it comes out the other end, it pretty much causes cancer all the way down. So it's not hard to remember. The one that's important to remember is female breast cancer, which may not seem quite so obvious. And as I mentioned a bit earlier, the key point now in the newer guidelines is that systematic reviews suggest that alcohol consumption as low as one standard drink per day is still associated with increased risk of gastrointestinal, so all of those cancers, and breast cancer.
Question. So the people will be recognising there's some question about it causing the health benefits of alcohol. Do you think those have been sort of put to bed?
They haven't been put to bed, no, but there's a lot more uncertainty, and there's a lot more uncertainty about those findings now, and there's much more study going into them, and there's study going into the previous findings, so more systematic reviews of that and analysis of that previous data, and more data coming out that's showing that
many of the people who reject this will cite the supported health benefits of alcohol as a reason why these sorts of messages are the wrong messages to give to society. So it's interesting to see the...
Yeah. They're shifting sand, I think, is the safest way of saying it.
Yep.
In terms of caution for alcohol use, 18 to 25-year-olds are classically at increased injury risk, so single occasion risk from drinking, and they drink at higher levels on single occasion than any other group in Australia. If you're older than 60, advising patients that you've got a decrease in muscle mass most likely. We know that muscle mass is where your glycogen is stored. Glycogen is stored with water. Alcohol, is a lipophilic and hydrophilic molecule, so it's spread everywhere through the body. So it's stored in your water tank, if you like, which is in your muscles. If you've got less muscle, that means for the same amount of alcohol, you're not storing it as much, it goes into the blood. So your blood alcohol concentration will be higher as you get older for the same amount of alcohol consumed. And the blood alcohol concentration is what's going into the liver and into the organs, etc. Lower metabolism, again, higher blood alcohol concentrations. We know that if you've got a family history, you're at a greater risk of alcohol use disorder. So people coming to talk to you about alcohol use and they've got mother and father with with alcohol problems, it's important to advise them that they're at much higher risk of developing an alcohol use disorder. Illicit substances and prescribed medications can cause interactions with alcohol that make them dangerous in a single occasion, things like overdose. Unchanged, that single occasion risk is still at 4 units per day, and no alcohol in pregnancy and no alcohol for those 18 years and under, where the frontal lobe is developing quite significantly at that stage. And that's everything from me. I'll hand over to Richard. Thanks very much, Richard.
Thanks, Mike.
I've just got one of the slides to check with you.
Sure.
Risk of cancer increase with consumption, but you also...
Yeah, so if you drink if you drink the same amount of alcohol over a short period of time, your risk also increases. So it increases with volume, but then if you just separately consider cancer you're drinking as well.
Okay, so that's the area.
Well, let's go there.
America has a different recommendation, 21 years.
No, 21 is their driving.
I don't know why.
No, I was just wondering did you want to go?
No.
3 years gap.
Yeah, look,
That would be beneficial for the growing brains, you know.
I don't know that specifically, but what we do know is that the frontal lobe doesn't complete development until 25. So I think their guidelines in terms of when alcohol should be legal are much more sensitive than 18.
Great, thanks, Mike. Look, this presentation is on public health policy changing substance use in society, and it follows on nicely with Mike's on the recommendations, the new recommendations that are coming out this year. And what I thought I'd talk about today is a couple of examples where we've identified problems with substance use in society and how we've responded to that on a public health in a public health forum. So the first one is just a review of what happened with codeine. As everybody knows, over-the-counter codeine was sold in Australia until February 2018, when it was rescheduled from Schedule 3 to Schedule 4, which meant you needed a prescription for it.
We don't know, buddy.
The story actually goes back quite a bit of time with codeine. Ever since the mid-2000s, there has been a recognition of issues in relation to the availability of codeine, and we progressively tried to address the problems we found with over-the-counter codeine in terms of dependence and harm from it through a number of mechanisms. And those mechanisms were to make the requirement from over-the-counter, no pharmacist involved, to over-the-counter with a pharmacist involved. And you can see over a number of years, a number of changes to codeine availability eventuated, culminating in 2018 when it became prescription only. There were a number of discussions leading up to this, and a number of bodies around Australia were putting their weight behind, we really need to do this. The RACGP, the AMA, the Pain Australia, a number of people were saying we need to make a change to this. However, there were a number of people who were opposed to it, specifically the Pharmacy Guild and the Pharmaceutical Society of Australia did raise some concerns about what people would do in relation to overregulation, the cost of pushing that availability onto GPs. In other words, a tsunami of people going to see their GP for prescriptions for Panadine Forte, and it was estimated that it would be expensive. The reasons why we identified we needed to do something about codeine, number one was we found there were a lot more people over the years presenting to AOD treatment services saying, I've got a problem with over-the-counter codeine. And a number of people being recognised in hospital as having very, very severe injury in relation to, not the codeine of course, but to the paracetamol and or the ibuprofen that was with people using, Panadine Extra and what was it? I can't even remember the name. Nurofen Plus, yes, thank you. And of course, we did recognise codeine increasing number of people were actually coming to not just harm but to die in relation to codeine-related deaths. It was observed that they were contributing to the already large number of people who were dying in relation to an opioid overdose. And most of that, of course, is pharmaceutical opioids. Why were they removed? A number of papers were being published over the last 10 years or so. Essentially, more and more literature was being produced saying we've got a serious problem with mortality and morbidity, and the trends in accidental and intentional overdoses were just increasing. And thirdly, the arrangements that were in place to try to contain the harms that were associated with codeine in terms of we have the program where it had to be pharmacists had to provide the codeine, and additional means, they simply didn't work, restricting packet sizes. And it's interesting to relate this to the changes that Thomas spoke of a little bit earlier. We're now looking at restricting packet sizes for stronger opioids, and I guess we'll know in 3 years, 5 years, 10 years, whether that's been effective or whether we indeed go to different forms of regulation and containment of harm over this. There were counter-arguments that arose, and the one I heard a lot of, look, so like everything else, you have one or two people who overdo it, so everybody has to pay the price. And I'm not going to be able to get pain relief anymore. My pain conditions that I've been sorting out myself, I now have to go and see a doctor for, or I just won't be able to treat them. In response to that, a lot of data came out saying, well, basically, the amount of codeine that you're getting in over-the-counter products isn't helping your pain, but it is contributing to people who like codeine or who are looking for the codeine effect coming to harm from those products. So the arguments against the change in regulation didn't really stand up, is what I'm saying. The outcomes, what happened, it was rescheduled. You had a drop in codeine-related overdoses. That was a study conducted in Brisbane Hospital. Reduced calls to poison centres regarding codeine. We didn't see a shift in overdoses in relation to stronger opioids. We have had an overall large decrease in the sale of codeine in Australia. It was around 50% between 2019 and 2018, 2017. There was a significant loss of use of codeine without a shift to other strong opioids, which was one of the expected outcomes from some centres. At next step, codeine was rescheduled here. You can see the blue lines basically saying this is the amount of people who are attending our service in relation to codeine problems, and it hasn't dropped completely, of course, because codeine is still available, but there was a significant decrease around about the time that codeine became more restricted. And of course it put us in line with other jurisdictions around the world where codeine has been not available over the counter for many, many years. Public health approaches to reducing alcohol-related harms. I wanted to talk today about one such process. This graph is basically what's the tax you pay on alcohol in Australia. And I've circled there, you've got cask wine only, the tax on cask wine is minuscule in Australia, which means that cask wine, which has the same amount of alcohol as bottled wine, is taxed on a very, very low proportion. It's cheap alcohol compared with the other end of the spectrum, which is the premixed spirits and spirits.
And so, Richard, so also in the mixed-drink beer on tap, I mean that was specifically done to increase people's use of mixed-drink beer, but it's still higher than cask wine.
Yes. There's no logic that I can see behind the fact that a very cheap product that has significant alcohol in it is widely available in Australia. So I'll talk more about that. So we're looking at what are ways to impact on alcohol sales and thus have an impact on public health in terms of the harms that are associated with alcohol. And again, we come back to there's a number of studies that have been produced over the last few years, and one of the issues or one of the strategies is to say, well, okay, we'll equalise that graph by putting on at least a minimum amount of tax related to the content of alcohol, so a minimum unit price per standard drink. So regardless of whether you're drinking wine, beer, spirits, champagne, if you're drinking in a hotel, and this only applies to where you can buy alcohol, we're not talking about takeaway alcohol, you will pay a certain amount of alcohol per standard drink. Because if you're looking at the graph that I showed to begin with, you might say a standard glass of cask wine might be 20 cents, and you might pay $2.50 for a standard glass, or you pay a lot more than that for a glass of wine or spirits in a pub. So how can we make that more equitable and have an impact on very, very cheap, readily available alcohol? And it's through this minimum unit price. Bottom line, what do we think it does? They've been shown to reduce the proportion of young people who are heavy drinkers, reducing underage binge drinking, and it slows the progression towards drinking larger amounts. And there's a lot of evidence that has been researched around the world on what is the impact on changing the pricing of alcohol in this particular manner. And of course, as in all public health change policies, there are counter-arguments. Doesn't alcohol taxation unfairly impact on those in lower socioeconomic groups? The answer is no. It's basically a user pays system where if you drink more, you pay more. And the corollary of that is that if you're somebody who's more exposed to the harms of alcohol, you'll actually benefit from this if it has an impact on you, reducing your alcohol intake. So the greatest effect is on heavy drinkers because they drink the most, not sort of rocket science. And essentially, volumetric tax extracts compensation for taxpayers for the social cost of alcohol from drinkers directly into the proportion of alcohol they consume. So essentially it's a way of clawing back some of those costs to society from hospitalisation, policing, childcare arrangements, treatment services, that sort of thing. An example of this in Australia that's happened over the last couple of years is the effect of minimum unit pricing in Northern Territory. They introduced it in October in response to a number of problems, a recognition of overuse and the harms in that jurisdiction. They thought, well, okay, what are we going to do? They put on a minimum floor price for alcohol of $1.30 per standard drink. So you could not buy alcohol that was cheaper than that when you're being served at a venue. There was another public health policy in place at the time, the BDR, which is the Banned Drinkers Register. That's been in place for some time, whereby if you are identified as a person who has problem alcohol consumption, you can be banned from actually accessing alcohol from bottle shops and so forth, and that's been in place for a little while. Another policy. So what was the impact? They introduced it, and then there was a 12-month review of what was the impact of this policy in the Northern Territory and they compared before the policy was introduced to the year after the policy was introduced. So this one is in relation to alcohol-related assaults in Northern Territory. So you can see the bar, the brownish bar on the left was prior to the introduction, and the grey bar was post the introduction. You can see there the 43%, 28%, the reduction in alcohol-related assaults, which is one of the issues that gets spoken of in the media all the time. You hear of these one-punch issues, and that led to Sydney lockout laws, another public health policy to reduce harms related to alcohol, particularly heavy alcohol use on weekends and in nightclubs and so forth. Yes, yes. The other, the bar on the right was the overall harm reduction in 26%. The other matter that was addressed was domestic violence, and you can see again the overall reduction in the Northern Territory was 21%. The areas have been divided up based primarily on when the introduction of the change to alcohol policy was introduced. It's been in practice in Alice Springs for longer than other places. And I think I've got that listed here. Effectively, the biggest changes were in places where the policy had been introduced earlier, and so you got a bigger difference in Alice Springs. Another measure was emergency department presentations, which showed dramatic reduction as well. Indeed, to link this with Sydney lockout laws, there's studies that were conducted on the lockout laws in Sydney that showed a similar effect of reduction in presentations to local hospitals, and there was a slight shift in presentations to hospitals outside the lockout area because there was a small, if you like, pushing of people from King's Cross to other areas, but if you looked at the whole system, it wasn't as much as you would expect. So there was an overall improvement in the number of alcohol-related problems when Sydney did introduce it. However, Sydney has reversed that law because of economic interests. So economic interests were of higher value than ED presentations, domestic violence and assault, which is, these are the battles that are conducted for public health matters. And I put this one up simply because it's an example of when I was reading the paper, you've got the really cheap alcohol being advertised at Dan Murphy's, $40 for a carton, next to a story on the page opposite, where you've got drunken teenagers, schoolies rather, having significant harms, because we all know that schoolies weekend is one where there's a lot of binge drinking and really, really hazardous use of alcohol. I thought that was just it really spoke to the fact that we've got a long way to go to sort of have a society where we're not sending out these mixed messages, essentially. Maybe in a year's time I'll talk about the public health policy that occurred in Western Australia to achieve pill checking, because we're basically not going to do that in Western Australia at the moment, but as time goes by, that will be one of the public health matters that will probably change as time goes by. Thank you. Any questions or queries?
Any questions online from anyone?
We might not have the
Oh, sorry, I don't. You're right. Thanks.
I have a question. This is the public health measure, but what's the feedback from the bottle shops, that sort of society?
terrible idea.
I mean, how does it impact on their income? And what about the actual public? I mean, do they actually welcome this because there's less drunkenness on the road, there's less road accidents, there's less of everything? Are they happy, or are they thinking, again, a big brother kind of watching over what I do? How dare they?
It really comes down to some extent what's who you're talking to and who's got the loudest voice. So we get news reports where they might interview the person in Western Australia who is the spokesman for the hoteliers, and he will say, as he did when we restricted alcohol sales during COVID, this is terrible. There's hardly any problems. We're punishing the whole society for one or two people having a problem with it. The job of part of the job of the Mental Health Commission is in promotion, alcohol promotion, and we actually do a good job in promoting a healthier attitude towards alcohol. But it's a competition based on, available funds and who's going to pay for advertising. So I can't answer that specifically. It really depends on the person, on who you're asking, and also who's been doing a bit of promotion lately.
I think there's some comment from domestic violence advocates in the Northern Territory that advocates domestic violence, people that
counter. They're not advocating for it.
Yeah, exactly. Let's just try and make that clear. The improvements with the minimum unit price have been outstanding, and if you can look at 21% reduction. If there was a single intervention that you could put in place for domestic violence that would reduce it by 20%. This is just a remarkable amount, and the same thing happened in Scotland.
Yep.
And that minimum unit pricing changes harm almost from 1 month to the next. It's just so dramatic.
But
yeah,
it's such a great cost, and the cost is we don't make as much profit when we're selling beer and wine.
That's what I'm saying. There's a lot of revenue to the state as well.
That's true, and the wet tax, going back to Richard's initial point about wine, 13% versus beer, which is 3%, and paying less for the wine. That wet tax has been around for I don't know how many years, many years, and it's been through something like 5 federal government reviews, where it's been put off to review. There's been some sort of whatever review process. They've come back with a big document, and it's still been shelved. And that's just the industry. The wine industry's voice is loud. Which is
what are those people called who specifically promote lobbyists? Yeah. Very, very strong group of people. Because there's a lot of money to be involved and there's a lot of vested interests.
What's really interesting with this, and also the rescheduling of codeine that Richard showed earlier, is that the concerns about this is going to harm lower socioeconomic groups. That's the alcohol. What's going to happen to industry, etc. All of that sort of stuff. The industries are still going, and we've reduced harm massively. And then with the over-the-counter codeine, this is going to leak into other opioids. Doctors won't be able to manage this. There's going to be a crisis with GP presentations. And with the lockout laws as well. This is going to spread the problem somewhere else. It's going to be terrible problems elsewhere. None of that has been evidenced in the literature, which is just a fantastic outcome.
These sorts of arguments come up. They came up in the 60s when we had to introduce driving seatbelts, and who wouldn't drive without a seatbelt these days? Or indeed things like pool fences. In time, we will look back on this and say, well, that was a no-brainer. Why didn't we start that, years and years and years ago? But it needs time, and it needs a shift.
Well, I come from a time when tobacco I've never seen an advertisement except in historical things. Do you think that we'll get to a point where there will be a move towards alcohol advertising the same way? No. Or is the industry much bigger than the tobacco or more powerful than tobacco was?
At the moment, alcohol advertising in sport is a particular problem. There's a whole group of people that are advocating for reducing alcohol advertising in sport, because kids can still see advertising. Whilst it's limited at certain times, it's not limited in sport. So you can be watching a cricket game in summer at 7 o'clock in the morning from the eastern states and be watching adverts for beer when the toddler's on the floor. When the young kids are on the floor playing. So there's a lot of advocacy for it, but I don't know, Richard, if you've heard.
Well, who would have thought, if we were in an advertising agency with all mad men in the 50s, they probably never dreamt that smoking would be essentially banned in most places. I see a time when actually advertising will be stopped, but the question is, how will we move from where we are today to an area where there's much less alcohol consumption and promotion and a whole change of culture? It's really interesting to wonder about that, but I do see it actually moving to there, but perhaps not, in 10 years or 15 years. It might take 20 or 30.
I think there's more movement for it.
I do too.
Going back to the advertising in sport, for example, Cricket Australia had a lot of negative feedback from their. They were sponsored by Carlton United Brewery, and all of their products, and that was listed as their main sponsor. And Carlton United Breweries were going to have a great time over summer, and have all these prizes, etc. So that as my understanding is, they don't have that sponsorship anymore, and that was worth a fortune. But they have decided, given all of the public and advocacy groups that have talked to them, they've decided to get rid of that. So, there are things that change.
10 years ago, I was in Melbourne having breakfast, and I had a copy of the Herald, and top of the page, front page was, with every paper you get a free stubby of VB. That was the promotion at the time. I took a photo of it, couldn't believe it. I didn't even get my VB free stubby either. It was just crazy. And we'll look back and I think, who on earth could ever do that? As we probably do with tobacco from the 50s and 60s and so forth.
But I don't want to see the alcohol or tobacco to be banned, like, you know, in the old days. I think that's just going to drive an underground market where it's even harder to police and you sort of have more, you know, if you say like total ban, with no alcohol to be consumed or sold or manufactured, I think that's not going to be the extreme.
I think a lot of people would agree with you.
I'm not
sure that will be the
It's
case.
going to be a problem, a bigger problem, a bigger profit to be made.
I think tobacco is different though to alcohol. I think tobacco will be banned eventually because there's I think it's seen differently. But who knows? There are pushes. There are jurisdictions where it has been banned. All right.
Thanks for listening.